This program is a presentation of UCTV for educational and non-commercial use only.
My name is Dr. Chris Dowd, and I'm in the Interventional Neuroradiology Division of the Department of Radiology and Biomedical Imaging. And it's going to be my pleasure to host the session tonight on stroke diagnosis and rapid treatment. Time is of the essence. It's a very dramatic title. There are two things I want to accomplish tonight. One is to teach you something and have you learn something, and the other is to have fun. And those two go hand in hand, and hopefully we'll all be able to do that. I guess this is kind of like medical school, but let me give you a taste of the real medical school. My first day of medical school, the person in the front said the following to us. Ladies and gentlemen, welcome to medical school. Each of you, look to your left, look to your right. One of you won't be here next year. That's a great way to start, isn't it? Some of us survived, even some of us that sat in the back row. Okay, as we begin, some disclosures, you've probably seen that. A couple of things I'm going to discuss are not approved by the U.S. Food and Drug Administration. Use of off-label use of medication, tissue plasminogen activator. I'm going to show you some vendor images for illustrative purposes, not to promote anybody's product. And I'm also a scientific advisor to a company called Neurovasics. In terms of full disclosure, that has nothing to do with the topic tonight. And as I begin, I want to thank my following comrades, each of whom in his own way helped contribute to this. Joey English, Steve Hetz, Wade Smith, Van Halbach, and A.D. Josephson, either in the interventional neuroradiology or neurology divisions, helped me with this talk, and I'm grateful to them for their help tonight. Okay, stroke. It's kind of a scary word, but even in my career, in the past 2+ decades, this has evolved quite a bit. So here's kind of where we've come in the last 50 years. It's only been about 50 years that we've talked about treating acute stroke. Before that, it was, sorry, we can't do anything for you, hope you do okay. But it was really about 50 years ago that we thought maybe we could intervene on somebody that was having an acute stroke. And this is a timeline that shows how we got to where we are today. Some of the things that have really advanced our ability to do this were the development of imaging, such as the CAT scan, became widely available in the 70s. That changed everything. Then people started using thrombolytic agents, such as urokinase or tissue plasminogen activator. They're clot-busting agents in order to break up the clot that was blocking the artery in the brain. And this was anecdotal use of these agents in the 80s when I started doing this, and into the 90s. And then we started doing some real research. There were several trials that led to the development of the use of the medication tissue plasminogen activator intravenously for acute stroke, these trials here. And it wasn't until 1996 that the very first therapy for acute stroke was approved. And then as we've developed more imaging, beneficial imaging protocols and devices to treat stroke, this is how we got to where we are today. So we're going to go through some of these therapies for you. This is my outline for tonight. So this is what you're going to hang your hat on. We're going to talk about what is a stroke, classification and basic neuroanatomy, epidemiology and risk factors, what you can do to try and prevent yourself from having a stroke, the warning signs of a stroke. That's very important. People are very interested in that and what that means. What happens from the moment you have a stroke through triage to the emergency room to when you get treated? That's a very important interrelated chain of events that we're going to go through. Then we get into my realm here, how diagnostic imaging helps guide therapy, and then the acute stroke therapy itself, including the endovascular techniques, which I am the one who carry out. So let's talk about stroke definition, classification, and basic neuroanatomy. First of all, what's a stroke? The abrupt onset of a focal neurological deficit produced by a vascular mechanism lasting 24 hours. So the key words here are abrupt, focal, and vascular, okay? General confusion and malaise, that really doesn't fall into this category. It has to be abrupt, and it has to be a vascular mechanism. The same criteria that last less than 24 hours, and usually much shorter than that, is something we call a TIA, or transient ischemic attack. You may have heard that term before. And I love this word, apoplexy, to be struck down by the gods. And if you look at this New York Times article from 1923, it describes the stroke of apoplexy at 7:30 p.m. of President Warren G. Harding. And this occurred right downtown at the Palace Hotel in San Francisco. We have some history buffs right here. But, you know, apoplexy sounds like a term that your great-great-grandfather would use. I just love that. Now, it's really not clear that President Harding had a stroke. He may have had a heart attack. But why let the truth get in the way of a good story? That's what the New York Times says, so that's what we're going to go with here. Now, there are other things that can produce the abrupt onset of a focal deficit that aren't strokes, and they're not vascular. A seizure, that's an abrupt onset, but it's not a vascular event. Migraine headaches can be the same thing. So not everything that's an abrupt focal neurological deficit is a stroke, but I would worry about stroke first because that's the most dangerous and something that a delay in treatment may cause you to have some problems. All right, let's go on to some neuroanatomy. I know most of you know all this all the time. You discuss it at dinner, but let me go over a few basics for you just for fun. This is just to make sure that I actually went to medical school and that I know what I'm talking about, right? Okay, so here's our brain. Parts of the brain we're going to talk about. Right here, this long segment here is called the brainstem, and this is what connects up to the spinal cord. That's the most primitive part of the brain. And behind that, we have this striped area called the cerebellum. This controls smoothness of motion, kind of like the rider on a horse. But most of what we're going to be talking about are the hemispheres, or the cerebral, or the cerebrum here, which looks like that thing that you see in horror movies with the infoldings and whatnot. And this is what's developed most prominently in man since we were apes. We divide this into 4 lobes just for discussion purposes. Frontal lobe here in the front, the parietal lobe, the occipital lobe, and the temporal lobe. And that's how we name them. Now, all of this real estate is not created equal. There's some high rent districts and low rent districts, and we're going to be talking about the division of labor within the brain. So important parts of the brain. The brainstem here has some very primitive functions, breathing, moving the eyes, whatnot. Vision is mostly situated here in the back of the brain. And important motor function is along the stripe that runs along the back of the frontal lobe here, this red stripe. This is what moves your arms, leg, and face. And what is able to provide sensation is the blue stripe right behind that. Speech is a very complex neurological mechanism which involves the angular gyrus all the way around here. Think of speech input coming in here in the primary auditory complex. Then you have to digest the speech, and speech output or production is about here. So speech is among the most complex neurological functions. Now, you probably think that's pretty scary, that's a lot to learn. I'm going to boil it down to you for the final exam. This is really all you need to know, okay? That's really human function in a nutshell. And those of you, there's a couple of you who know me here, this is a cortical map of my own brain. Married participants recognize that here in the occipital lobe, that undergoes atrophy earliest. All right, enough of the joke slides here. All right, now we've talked about the parts of the brain and the function of the brain, but we're here to talk about the blood vessels and what happens when you block them in the brain. So let's look at the blood vessels and how they get to the brain. Your heart pumps blood to the main blood vessel here in the body called the aorta. And the aorta then pumps blood everywhere in the body, including up to the brain, to the paired carotid arteries on the right and on the left, and the paired vertebral arteries on the right and the left. The vertebral arteries come together to form the basilar artery, which runs right in front of the brain stem here. So you have the basilar artery and the paired carotid arteries, which fill the circulation in the brain. And I'm going to show you how that fills the brain here. So the basilar artery comes up the back here to fill what's known as the posterior cerebral artery territory, and the carotid arteries fill the middle cerebral territory over the side of the brain. And what you can't see in the middle is the anterior cerebral territory, which fills in the middle of the brain. You can't see here because it's not cut away. So if we overlay the vascular imaging and the function of the brain to the, and here we have the middle, anterior, and posterior cerebral territories, there's our function map, and there's our blood vessels overlying it. So we can predict when a certain blood vessel is blocked, what part of the hardwire computer will go out. For example, this is the dominant temporal lobe. In most people, it's the left side. And we know that if you block the middle cerebral artery on this side, this yellow territory here, you're likely to get a problem with speech, and you're likely to get a problem of moving the face and the arm on the other side of the body. Some of you may remember that the brain is cross-wired. The left side of the brain moves the right side of the body and vice versa. That's actually true. I'm here to tell you that. So you can predict, depending on which blood vessel is blocked, what kind of neurological problem you're going to have. And that's about as much neuroanatomy as we need to get into tonight. Let's talk about stroke classification. There are basically two major kinds of stroke: bleeding strokes, hemorrhagic strokes, and blockage strokes. Ischemic strokes. Ischemic is a word that means not enough blood getting someplace. Imaging is very important to differentiate these two. These are bleeding strokes here. This patient who fell has a subdural hematoma. This patient has an interparenchymal hematoma. And this patient has this ruptured basilar tip aneurysm that's causing what we call a subarachnoid hemorrhage. These are all bleeding strokes or hemorrhagic strokes. Ischemic strokes means that a blood vessel is blocked. If you think of plumbing, we're talking about a clogged pipe rather than, on the left, a leaky pipe. And in general, we can talk about large vessel versus small vessel strokes. Here you can see there's a large territory of the left middle cerebral distribution that's injured this entire part of the brain. That's a large vessel stroke. And here on this MRI scan, you can see this little white spot here in the right thalamus. That's a little tiny perforating branch that's caused a small vessel or a lacunar stroke. Lacunar is the Latin word which means little lake. And either of these strokes can be produced by one of two mechanisms: embolic strokes and thrombotic strokes, which we're going to talk about. Now, I'm happy that some of you are taking notes, but remember, part of this is supposed to be fun, too. All right, so let's talk about the strokes again. Hemorrhagic strokes is a leaking pipe, rupture of an artery, bleeding into or around the brain. This is about 15% of strokes. Clinically characterized by an abrupt onset of a neurological problem, usually and with a very bad headache, and progressive decline in mental status. Whereas the ischemic, or not enough blood supply stroke, is a blockage of an artery. This is the majority of the strokes, 85% of strokes that occur. Abrupt onset, but usually preserved alertness and awareness. However, I will tell you that it's usually not possible to differentiate between these two without imaging. and which is, of course, why it's in this section tonight. So proper imaging studies are mandatory to decide which kind of stroke you have. Now, what we're going to eliminate these strokes. That's a topic for another day, and talk about ischemic strokes. That's what we're here to talk about tonight. So two major mechanisms of the ischemic stroke: large vessel strokes and small vessel strokes. So let's look a little bit more at the vascular anatomy about how these are produced. Okay, so here's our brain. It's a cutaway of the brain. Our carotid artery comes up and branches into the middle cerebral artery, a large vessel, and the anterior cerebral artery, a large vessel. And you can see these little tiny vessels that come off. These are perforating or small vessels. Now, the difference between the two is if you block a large vessel, oftentimes it has the capacity to have collateral blood supply come around and try and fill in behind it, do the best it can to perfuse that part of the brain. If, however, you block one of these small vessels, although it's a much smaller territory that we're talking about, and therefore not as much brain at risk from having the cells die if you block it, but there's no potential for collaterals to that part of the brain. So if you block one of those small vessels, which usually occurs from atherosclerotic disease, high blood pressure, diabetes, these vessels just get clogged enough to block off. That's when you end up with the small vessel or lacunar stroke, which could be silent or could be perfectly positioned to give you a significant neurological deficit. So that's the difference between the large vessel and the small vessel stroke. Very important for what I do. We try and identify the large vessel strokes because those are the ones that I'm asked to go in and treat and try and eliminate the clot. Now, the other type of stroke, the other way to think about stroke is not whether large or small vessels are affected, but how the stroke is produced. And there are really two ways that you can cause an infarction. An infarction is the term we use for dying or dead brain from not enough blood supply. And those two mechanisms are thrombosis, which usually occurs when you have narrowing and finally blockage of an artery such that not enough blood gets through that pipe, and this part of the brain is deprived of adequate blood supply. And when you get to that point, either you have collateral blood supply trying to preserve perfusion to that part of the brain around it, or if you don't, those cells will die. The other most common mechanism that I get called for in the middle of the night is the so-called embolic stroke. And the typical mechanism for that is a blood clot that may be produced in a chamber of the heart, is produced there, breaks off, ends up in the circulation and gets pumped to wherever the blood will take it. And of course, I get called when it gets pumped up into the brain and lodges in one of the arteries in the brain. That's called an embolic stroke. So within ischemic strokes, we have large and small vessel strokes, and we have thrombotic and embolic strokes. All right, let's look a little bit at epidemiology and risk factors for stroke. Fun facts, and please, you don't have to write them all down. I think most of them are in there. Fun facts for stroke. Nearly 800,000 strokes a year in this country. We're approaching that. We'll be approaching that this year. 85% of them are ischemic strokes, 15% are hemorrhagic strokes. 17% of patients who have a stroke will die. That's 137,000 deaths in this country a year, the third leading cause of death, and the single leading cause of disability, chronic disability to patients. Huge annual cost if you consider both the direct cost of patient care and the indirect cost, jobs lost, etc. $76 billion. Now, as it turns out, women have more strokes than men. Does anybody know why that is? Because you live longer. That's right. That's right. So that's kind of a little bit of a fractured statistic. And men have a greater stroke incidence in a younger age, but that risk equalizes as women pass through menopause into older age, and of course you do live longer. African Americans have twice the risk of a first-time stroke as Caucasians. That's not fair, but that's the way it is. If you have a TIA, 40% of those patients will go on at some point to have a stroke. So we take TIAs very seriously, a real warning sign. Oh, I love these statistics. About 2 million brain cells die each minute during a stroke. This sounds like some of the things that your mother warned you before you went to college. A stroke about every minute in this country, and a stroke death a little over every 3 minutes in this country. Some daunting statistics. That's why we take this so very seriously. And you're thinking, wow, I don't want that to happen to me. How do I avoid that? Well, there are things that you can change and things that you can't change, and there they are. Things that you can change, and by the way, you can really change your stroke risk, your cardiovascular risk, your risk of having a heart attack by working on these things. Hypertension, high blood pressure, it's the silent killer. You don't know you have it, and sometimes if you do have it, taking the medication for it makes you feel worse than actually having the problem. High cholesterol. We've learned that we really try and drive people's cholesterol down because we accept as bad lower cholesterol rates than we used to think. Diabetes, we just need to treat it. Smoking. When I am the Surgeon General, that's what I'm going to go after next. Smoking is very vasoactive, and it's very causative of a stroke. Inactivity and obesity in and of themselves aren't risk factors for stroke, but they contribute to hypertension, hypercholesterolemia, and diabetes. Atrial fibrillation. We talked about the embolic mechanism of a stroke. This is a condition in which the heart does not beat regularly. So it kind of flip-flops. And when it doesn't beat regularly and flip-flops, you may be pumping enough blood to your body, but that's where the little blood clots can form in a portion of the heart called the left atrium. And if those clots form and then break off and get carried out into the bloodstream, that's a risk of stroke. And I would say most of the strokes that I treat are from untreated atrial fibrillation. When one has atrial fibrillation, the proper treatment is either to correct the heart rhythm back to a normal rhythm or to be on blood thinners to prevent the development of those blood clots. Very important thing. And I would say most of the strokes that I treat are people who have atrial fibrillation, AFib, and are not on adequate blood thinners. Things you can't change. Well, the only way you can change age is by not getting any older, and that's not going to help any of us. Gender. Some people try and change that, but that's hard to do. Heredity and race, you are who you are, and that's the way it is. If you've had a prior stroke, a transient ischemic attack, or a heart attack, that puts you at risk for a stroke. You can't do anything about the fact that you already had it, but you can do something about the risk factors that led you to that stroke in the first place. So fun facts and risk factors for stroke. Let's go on to warning signs of a stroke. I know everybody's kind of already highlighted that section of it. Okay. Anybody remember this show? Sanford and Son? Now, this is a decades-old show, but when things weren't going well on the show for Fred Sanford, he'd grab his chest and pretend he was having a heart attack. And that was a very effective visual because everybody knew what a heart attack was, how dangerous it was, and we all knew that if you're having a heart attack, you better get the patient to the doctor right away because somebody might die or let's do something. Well, we never used to think that way about stroke until recently. As it turns out, we should be thinking about stroke in that way. Just as we call heart attacks, we call strokes brain attacks. And that gets people thinking. In a recent survey, only 44% of patients identified weakness on one side of the body as a sign of a stroke, less than half. Less than half the patients could identify any stroke symptoms. And the average time from symptom onset to making a phone call to the EMTs to call 911 was about 3 hours. And if you wait 3 hours before the phone call is made, we really can't help you. Most of the people who are excluded from the ability to be treated acutely for stroke are excluded because they didn't arrive in time. So very important, time is, you'll hear time, it's a very important element in what we're talking about. Okay, so what do we look for? And I have a more succinct list for you, don't worry. Common stroke symptoms: sudden weakness or numbness of the face, arm, or leg, usually your one side of the body. Sudden weakness. Sudden confusion, trouble speaking or understanding. Sudden vision problems, can be either on one eye or both eyes. sudden dizziness or loss of coordination or balance, or a sudden severe headache without a known cause. You're not having a shouting match with your spouse or something like that. Now that's usually the sign of a hemorrhagic stroke, not an ischemic stroke, but we want you to take that seriously. Those are a lot of words. Let's boil it down to, well, before we get to that, one strange thing that can happen in a stroke, and that is your brain is the alarm system that can tell you you're having a stroke. But it's possible that the stroke is going to disarm your alarm, and therefore you won't know that you're having a stroke. We call that condition anosognosia, not, nosos, like noxious meaning disease, and gnosis meaning knowledge. Somebody doesn't have knowledge that they have a problem. And that's one of the problems that you can have, not all the time, but you can have with the stroke. I love this little public service advertisement. A stroke attacks the brain alerts your body to danger. Do you see the problem? So, and that coupled with the fact that you may have language problems, you can't say anything to people. So sometimes you have these issues that don't even allow you to pick up the phone and call 911. But these are the things that I want you to hang your hat on. And I've borrowed this from the Massachusetts Department of Health. One of the few good things that's come out of the state of Massachusetts. I'm from there, so I can make fun of it. The acronym FAST, face, is there weakness or droopiness on one side of the face? Arm, if you ask somebody to hold their arms up, can they hold them up equally, or does one side drip down because somebody's not strong enough to hold it up? S is for speech. Can somebody understand you? Do you have to repeat yourself? Remember, speech is a complex thing, so they have to not only understand you, but then produce coherent speech. So either one of those things could be a sign of a stroke. And if you have face, arm, or speech issues, remember the T in FAST, which is time to call 911. This is from, this little ditty is from the Massachusetts Department of Health, and it kind of goes through this little acronym of FAST to us.
Someone you love could be having a stroke. Learn these signs, act fast, give them hope. Face is the truth when you ask them to smile. Does one drip down on either side? Speech, does it sound confused or strange? Then it's time to call 911. Face, arm, speech, time, act fast. With every second, brain cells die. Call 911 at any sign of stroke. Act fast. Give a loved one hope.
See, I got the dance in there. I knew I was going to do it. I told you we were going to have fun. Okay, you want to, am I going to have a stroke? If you remember, just remember FAST. Face, arm, speech, time. Time is a very important part of this. Okay, now, let's say you've gone all through this. You think that mom is having a stroke. What are you going to do? Pick up the phone and call 911. That starts the whole chain of events. We can't help you until you do that. Okay, and this is where it's so important to have public outreach here, because we can have the best doctors, the best hospitals, the best therapy, and if we don't know that you're there, we can't help you. So there's been a lot of public education lately going out to try and get people to trigger this, and I think it really has helped people. So what happens after you have your stroke? How are you triaged from the place you have your stroke through the emergency room to get acute treatment? So let's look at what has to happen here. And I have a little picture timeline of what needs to happen. And you see, we keep highlighting the word time here. Okay, you have your stroke. You've got to recognize you have your stroke, or somebody has to recognize that and call 911. Okay, you just have to be brave enough to pick up the phone and do it. Okay, then we have to have trained emergency medical technicians trained in stroke, and there's a lot of education going on there too, to get to you right away, to stabilize you, do what they need to do, and to transport you not just to any emergency department, but to a stroke certified hospital. And we here at UCSF, as our other hospitals in the area, are stroke certified, so that when you actually get here, we have emergency physicians here all the time who are plugged into this. We have neurologists on call here 24 hours a day who are available to administer a tissue plasminogen activator, which is one of the first-line therapies for stroke. We have 24-hour radiology to be able to do and interpret the imaging studies. And we have my colleagues and I, interventional neuroradiologists, who, if needed, can go into the brain and try and get rid of the clot. So these are the things that need to happen. Now, that doesn't happen in 3 minutes. On a recent study, the biggest chunk of time, and by the way, each one of these vertical lines is an hour, so this is 3 hours, and this is 8 hours. The longer you take to call 911, the longer it takes to get to the end point here. We try and keep each of these blocks as short as possible. Certainly when you get here, we need to evaluate you, we need to image you, and we need to decide what the proper treatment is for you, and we need to enact that. But unless you make the call, we can't trigger this whole mechanism. So everybody's on board with this timeline. I don't see you till the very end of this timeline, but everybody's trained along the way. So when you get here, you get to the emergency room, you're stabilized, and we think you're having a stroke, how do we evaluate you neurologically? Well, there's a very specific neurological examination that we administer to you. It's called the NIH Stroke Scale. And we go through this quickly, but carefully, and we assign a stroke score to you. Now, everybody in this room, hopefully right now, has a stroke score of 0. You don't want to score high on this exam. The worst score you can get is 42, and that's a pretty darn good score, pretty darn bad score. If you're scoring a 10 on the stroke scale, that's a decent stroke. If it's a 20, that's a pretty bad stroke. And points are given for neurological problems. And a whole battery of neurological function is evaluated here: consciousness, motor, sensory, ataxia, speech, vision, and gaze. And I'm just going to show you what we use for this. This is part of the NIH Stroke Scale score. It's pages long. I didn't go through the whole thing for you. But there are 11 items on this. Item 1A is level of consciousness. So we determine if you're alert, drowsy, or what your response is to us. 1B, we ask you questions. We ask you, tell us your age and tell us the month. And you need to tell us both of those things correctly the first time. Otherwise, you're going to get a point or 2 points for that. And this is the way we quickly go through this. Motor function, we look for facial weakness. We talked about that. We ask people to show us their teeth, and you should be able to do that symmetrically. And if you can't do that, you get a point for weakness on one side of the face. This is the F in fast. This is probably the hallmark of having a stroke on one side of the brain or the other. We ask somebody to put his or her arms out straight like this, palms up to the ceiling, close their eyes, and hold their arms up. Now, if your eyes are open and you have mild weakness, you can compensate looking at your hand and trying to keep it up. If the eyes are closed, you may not notice that you have a drift of one arm. That's called a pronator drift, because the muscles are not able to keep that up. So I'm going to show you a video lent to me by my colleague Andy Josephson, and I want you to watch this man's left arm. He's having a stroke on the right side of his brain, so his left arm is drooping down.
Hold your arms up in the air like you're holding up a pizza. Spread your fingers apart. Close your eyes. Keep your eyes closed. Okay, open your eyes. With this right hand, can you tap real fast? And now with your left. Okay, and the last thing, just want to see your feet. With that right foot, can you tap on the ground? Real fast. Great. Try to do that with the left, real fast.
It's quite possible that on one side of your body, your arm may not work as well as your leg. That's quite possible. You can see that this man was unable to keep his left arm at the same level of his right. That's a sign of a stroke. And that would get you a point or 2 in the NIH Stroke Scale score. So I'm really taking you behind the scenes now. We actually, to evaluate speech, cognition, we actually show people pictures. We'll say, ma'am, can you please tell me what's going on in this picture? And that requires you to be able to see the picture, digest what's on the picture, have some higher cognitive function about what's going on, and then talk about what's going on in the picture. And you might say, well, there's a boy trying to get a cookie and there's a woman washing the dishes. But clearly there's a lot more going on than that. All of this water is coming onto the floor and this kid is about to crack his head from falling off the stool. Those are the kind of things we'd want you to say. By the way, the next time you see this picture, you're either in a neurological residency or you're having a stroke. Can you name these objects? Naming and repetition, very important for speech. By the way, repetition is the hallmark of any of the speech problems. Sir, can you please repeat after me? It's a sunny day in San Francisco. That's a hallmark to any of the speech problems that one might have. So glove, key, cactus, feather, hammock, chair. I got them all right. No points for me. Good for me. Reading. Now, obviously, this can be a problem if the patient's primary language is not that, but we do the best we can. You know how, down to earth. And this is articulation. This is more motor function of the lips. Mama, tip-top, 50-50. We go through this very quickly, but very thoroughly, and then somebody will come out with a stroke scale score of 0 to 42. Now, once we have that score in hand, we try and get the patient to imaging as quickly as possible, and we're going to talk about how diagnostic imaging guides therapy. So, what do we want to get out of all of this imaging? Well, really, we want to clear up these issues. Is this patient having a stroke, or is there something else going on? Because if there's something else going on, we're not going to activate the stroke team. If it is a stroke, is it a bleeding stroke? That puts us in that 15%. If it's a stroke and not a bleeding stroke, is it a large vessel stroke or small vessel stroke? And we may not be able to say that it's a small vessel stroke, but we usually can say it's a large vessel stroke, and that's very important to somebody like me. And then finally, let's say we know somebody's having a large vessel ischemic stroke. Are we able to go in there to salvage something, or are we too late already? So these are the things that modern imaging is able to help us with. What are our options when somebody's had a stroke and the emergency room is called and said, we need to find out what's going on? Well, they're really threefold: CAT scan, MRI scan, or angiography. And I'm going to leave the angiography, putting a tube in the blood vessel and injecting X-ray dye, till later, because that's really a secondary form of imaging in a stroke. Most hospitals in this country are either pro-CAT scan or pro-MRI scan, and there are pros and cons to each one. MRI scan gives you some additional data in terms of what's going on in the brain. It's a little bit more sensitive to ischemia or lack of blood supply, but it's a little bit more difficult to get. And as you may know, if you go into an MRI scanner, you can't have metal in there, so it's a lot more cumbersome to get somebody from the emergency room to an MRI scanner. That's why here we prefer CAT scanning. A little less sensitive in the brain, but much more quick and easy to use. And although there's a dose of radiation, if you're having a stroke, that dose is negligible. So we, at this hospital, champion CT scanning for our initial stroke evaluation because it's the quickest. And after all, we said time is brain. Now, when we talk about CAT scanning, and that's what I'm going to highlight from here on in terms of the imaging, there are really three parts to it. There's the non-contrast scan itself, which basically tells you, is there bleeding into the brain or not, and do we have a big stroke occurring already? There's CT angiography, which shows us pictures of the blood vessels, and we're going to have some fun with that. And then there's CT perfusion. That tells us, are there salvageable areas in the brain to go after and treat, or is it too late already? Now, let's talk about number one, CAT scan of the brain. A CAT scan is, yes, that's not any mummy. That's King Tut himself. You know, how many eons has it been since Tut was on the earth, but now he's finally getting his acute stroke CAT scan. This guy seems to be pretty excited about it. A CAT scan is really just a fancy X-ray picture. Some of you may have had a chest X-ray or broken a bone in your arm and had X-rays. A CAT scan is a fancy form of an X-ray picture. It uses X-rays that are shot out of an X-ray source, through the patient, and the attenuation of those x-rays, or what stops it, is measured on the other side. And this is done very quickly in a detector array around this gantry that goes around the patient's head or whatever other part of the body we're imaging. And this can be done with modern scanners very rapidly. You can get this whole study in a matter of about 10 minutes. CT scanning, angiography, and perfusion. And I'm not going to go into the more technical details about that, but suffice to say, we've come a long way in the 2 decades that I've been involved here. Scanners are much faster and much more accurate and give us a lot more information than before. So what do we want to see in part 1, the non-contrast part scanning of the brain? Well, these are kind of the things we look for. You may see a brain that looks perfectly normal. You may see a brain where the entire left middle cerebral territory already looks very dark. That's infarcted brain. That's a bad sign. That's a huge area of a stroke that's already occurring in this part of the brain. This looks pretty good until you look right here. That's one of those small vessel infarcts, or lacunar infarcts, that comes from a small perforating artery that runs to this part of the brain called the thalamus. So this is a small vessel stroke. This is a large vessel stroke. Sometimes these little lacunar infarcts are so small and so early that we can't detect them. So really, at this stage in time, we're not so much looking for this small infarct. We're just looking for the absence of this thing. This is a cute thing. If you look here, you can see right in this segment, there's a linear density right there. That's called a dense middle cerebral sign. And what you're seeing here is a clot that has come from the heart that looks rather dense here, that is lodged in the middle cerebral artery. And you can actually see that clot without looking at the blood vessels themselves. So I can predict to you that this patient has weakness on the other side of the body just from looking at that. And finally, there's some very subtle things that you can detect on a non-contrast CAT scan. And until we use CT angiography and CT perfusion, these are really the only things that we had available to us in order to look for strokes. Now, if you look at this person's brain, and this is very subtle, but these are the kinds of things that we neuroradiologists look for. Notice that this structure, this is called the frontal horn of the lateral ventricle, is a little bit bigger than this one. That's because there's some very subtle swelling on this side of the brain, and that is an indirect sign of an acute stroke. Now notice also here, you've heard that in the brain there's gray matter and white matter, and the gray matter's on the outside and the white matter's on the inside. You can actually see that on a CAT scan. You see this little dense stripe of white tissue here? That's gray matter, and the white matter sits below it. If you lose that little stripe, and I don't see that stripe over here, that's called an insular ribbon sign, and that's also a sign that that part of the brain has become a little swollen, and so I could determine, based on this alone, that this patient is having a stroke in this location. Then you have the easy stuff. Is there hemorrhage going on? Here's a patient with a ruptured aneurysm who's had a subarachnoid hemorrhage, and here's a patient who has a big hematoma from what's called a hypertensive hemorrhage. In other words, blood pressure that's gotten out of control and caused bleeding into the brain. So these are the kind of things that we get on the non-contrast study. And that's where it used to end until recently. As a matter of fact, many of the stroke studies only used non-contrast CT scanning. I think we're far beyond that now. And as a matter of fact, we're a little bit ahead of ourselves in being able to use the information scientifically in order to triage our stroke patients. So now let's move on to part 2 of the imaging study, or CT angiography, looking at the blood vessels themselves in the brain instead of just the brain parenchyma. Okay, CT angiography is the ability to look at blood vessels. We start an IV and we give a bolus of X-ray dye, and that X-ray dye circulates throughout the body, and we're able to see the blood vessels that way. And once we give this injection into the veins, we take a series of rapidly produced images that we start in the heart and go all the way to the top of the brain, and you can see those images produced here on the slide of the right. So we start down here, we're getting to the top of the brain, and we're going to start right down here in the heart, and this CAT scanner is slowly scanning all the way up through the top of the heart. Here we're getting to the clavicles. This is the thyroid gland. The carotid arteries are here, the vertebral arteries are here, This is the neck. If you look here, this is where the carotid artery branches into the internal carotid artery and the external carotid artery. My mother doesn't think I know all this. And then we get up into the brain substance themselves. We see the basilar artery, the middle cerebral arteries, and of course, we can slow it down and go a little slower than this. But it's amazing technology that shows us what we need to see. And you can do some pretty fun stuff with this. By the way, we use the word super duper a lot in medicine, such as, "Hi Bob, how are you doing today?" "Chris, I'm super duper." We just do that all the time here. I don't know where that came from. Look at these images. They're just amazing. And part of this is done for show, but look at this patient. You can see this carotid artery here. We saw the basilar artery in the back. We can see so much more than we're able to even 5 and 10 years ago. It's just incredible. So what are we looking for pathology when we do CT angiography? Here's a patient, by the way, here's our standard cartoon of a patient, middle cerebral artery. And if you look at this patient, and by the way, we can obtain these images in any plane. And if you think of these sections here, think of your brain as a loaf of bread. And instead of looking at the whole loaf at once, we cut it into slices and look at each individual slice. That's what you're looking at with the middle and the right-hand pictures here. And you can slice the loaf in any direction you want. This is slicing a loaf across such that the right ear is here and the left ear is here. This is slicing a loaf from top to bottom such that this is the right ear and this is the left ear, and you're looking, this is the top and this is the bottom. This patient has a normal left carotid and middle cerebral, but there's no flow to the right middle cerebral artery because there's been an acute blockage by a clot that came from the heart, which is lodged right here, right at the origin or the first part of this middle cerebral artery. So you know that this patient is likely to have weakness of the face and the arm on the other side of the body. If this were on this side of the body, in most patients, in most people, that's the speech hemisphere, they would also have a problem with their speech as well. So this is the power of CT angiography. Let's move to the third part, or CT perfusion, and this tells us, is there salvageable part of the brain? Okay, so what happens here? This gets fancier still. Instead of injecting X-ray dye and taking a series of pictures from the heart all the way to the top of the brain, we take a series of images at one slice, or actually at a series of one slices, and we image over and over and over at that slice as we watch the X-ray dye come through the blood vessels and leave. And that allows us to make a perfusion map of that part of the brain. When does the blood arrive? When does it leave? How much got there? And by blood, I mean X-ray dye, which is a surrogate for blood. And then we can make maps, such as the one we see on the right-hand side here. And there are really two maps that we can make out of this. One of them is called mean transit time, or MTT. How long did it take the X-ray dye to get to that part of the brain? And as you can see here in this patient, the X-ray dye took a lot longer to get to this territory, in this case this is the right middle cerebral territory, than it did the normal rest of this brain. It's not quantitative, but it's qualitative, and this is very helpful for us. Now the other map that we can make is not just how long did it take the blood to get there, but how much blood got there. We don't care how long it took, but did enough blood get there? And we call that cerebral blood volume, or CBV. And those are the two parameters we use to determine how extensive is your stroke and are you salvageable. Let's look at this concept from the point of view of an angiogram. Now, this is an angiogram. This is another type of test. This is a more invasive test where a tube called a catheter is placed in the blood vessel, run through the main blood vessels in the body, and I'll show you a diagram of that so it becomes a little bit more clear. In this case, it's placed in the carotid artery, and you can see here on this loop that keeps going through. In this patient, we know that blood supply takes a lot longer to get to the right middle cerebral territory, and you can see why. There's a blockage right there, so the blood that should get there directly takes a lot longer to get there, and it gets there by a collateral circuitous route. In this case, it has to go up here and down and try and fill in that territory. And how well those collaterals fill in that territory will determine pretty much whether or not you're going to have a stroke. Okay? So that's mean transit time. Now, this is a key concept for us in perfusion imaging. It's called the ischemic penumbra. This is a different patient, but this is a perfusion map of mean transit time. So we see in this segment in blue here, and this is the anterior cerebral territory, there's a blocked blood vessel that supplies this territory so that you can see blood supply takes a lot longer to get here than it does the rest of the brain. That's the mean transit time map. However, if you look at how much blood gets there map, there's a much smaller deficit right there. So you can see that this spot is a lot smaller than this spot. So this is called cerebral blood volume. It means that even though blood may take a lot longer to get there, there's a fair amount of blood getting there except for that one little location. And this is the kind of thing that we use to determine salvageability of a brain. So let's make a little map on the area that has a problem with blood volume, which is right there, and we'll take that map and we'll overlay it on our mean transit time map, and you can see that's much smaller than the overall deficit in mean transit time, which is in green here. What that means is what's in red isn't getting enough blood supply, and that's going to have a stroke no matter what you do, but the area in green is just getting enough perfusion to poop along, and maybe if you get there quick enough, you can save that part of the brain. This is called the ischemic penumbra, and this is the kind of thing we try and identify. Now, my former colleague Max Wintermark, who was here and is now the head of neuroradiology at the University of Virginia, has done some wonderful work on this, and he's much smarter than we interventional neuroradiologists, so he came up with this red means stop and green means go concept. So he's made it easy for even us physicians. This ischemic penumbra shows us that this part of the brain may be salvageable if you can get there in time. And this is the kind of information that allows us to think no longer are we just going to use the time of onset of the stroke and how long you've had it, but we're actually going to use this perfusion data to determine, are you salvageable? There are some people who have only been an hour and who have brain that's not salvageable, and some people who have been 8 or 9 hours who are salvageable. So this is going to allow us to move from a time-based therapy decision tree to a perfusion-based imaging, to a perfusion-based therapy tree. And I know that's a little confusing, but you're in the midst of that right now. We haven't done all the data that tells us that red is stop and green is go, but it's very, very important and exciting information for those of us who are involved in stroke. Okay, so let's get to the best part, which is, and this is where I come in. I used to do the imaging, but I only do the therapy right now. Acute stroke treatment, including new endovascular or through the blood vessel techniques. Okay, so we have somebody who has a blocked blood vessel, such as the one we see here. Here's an acute blockage, in this case of the left middle cerebral artery. How do we get from that to this? Okay, and you can see it's wide open and normal there. There are really two basic ways to do it. One is to dissolve clot, and the other is to remove clot. Dissolving clot requires clot-busting medication, thrombolytic medications, such as TPA or tissue plasminogen activator. Some of you may have heard that. It's also used in the heart to break up blood clots there. Other medications that have been tried in the past, urokinase, streptokinase, are generally not used anymore. And this can be given either intravenously as a dose or intraarterially, where we actually take a catheter and direct it all the way up into the brain, put it into the clot, and infuse our medication right there. Exciting stuff. As you might imagine, though, you don't want to give clot-busting drug to somebody who's had bleeding into the brain. That's a bad thing, and that's why that imaging is so important. Okay, so that's dissolving clot. How about removing clot? Forms of thrombectomy, actually going up in there and breaking up the clot, not so much with medication, but by using mechanical means. And there are two devices that have been approved by the U.S. Food and Drug Administration, which I'm going to show you, both of which we use here. Now, here's the concept. There are two ways I generally describe situations, either by sports analogies or food analogies, and you're going to get the food analogy right now. So let's say that your wife told you last night, please make the orange juice so we'll have it in the morning. And you forgot, and you left the frozen concentrate in the freezer. And you wake up the next morning a few minutes before your wife, and you remember you didn't make the OJ. So you run downstairs, and darn it if you're gonna make that OJ before she finds out that you didn't make it. Okay, how do you make that OJ really quick? It's a big clog sitting in that can, right? Well, it's just like dissolving a stroke. You can use some hot water, clot-busting drugs, and you can take a knife and cut it up in there and remove it from the can. That's the thrombectomy. Or you can use the combination of the two. And that's how I usually do it. So it's a little bit oversimplistic way of thinking about this, but that, when it comes down to it, that's really what we're talking about. Getting rid of that clot quickly to keep those brain cells from dying and restoring the blood supply before those cells die. Now, if you restore the blood supply after the cells die, it really doesn't matter because those cells are dead and all you're going to do is reperfuse injured brain, which could cause bleeding on top of the stroke that you've already had. So sometimes we have to say, you know what, the perfusion imaging isn't right, it's been too long, we're not going to go after it. And while that may be disappointing, it may be the best thing for the patient. How did we get to what kind of treatment that we use? Well, there are some studies on which we base our therapy. The NINS trial was the trial that allowed us to determine that intravenous administration of the clot-buster tissue plasminogen activator was actually better for people if administered in the first 3 hours of stroke. And there was another study, ECAS and some other studies that brought that timeline out to a safe 4.5 hours. But 4.5 hours is pretty quick. You have to have your stroke, you have to call 911, you have to get transported to the right hospital, you have to get evaluated, you have to get imaged, and people have to decide this is right for you and get the drug in there in 4.5 hours. It's pretty quick. There are some patients that have strokes in the hospital that we don't even get in time. So please be cognizant of this. It's not going to occur every day, but that's how we've determined. It's the NINS trial that allowed the FDA to approve the intravenous administration of TPA for patients. There was another trial that we were involved in back in the mid-90s called the PROACT trial. This is a trial of intra-arterial administration of thrombolytic agent. This is instead of going into the vein and just giving it as a shot, we actually took a tube and went up into the brain and deposited the clot-busting medication right in the clot. Now, that was promising, but it wasn't promising enough to lead the FDA to approve that. So the intra-arterial administration of clot-busting drug is something that we use, but we use that in what's called an off-label basis. The drug has been approved for something else, not for this. But if we think it's right for you, and if you're my mom and you're having this, I'll think about doing that for the right thing. Now, there are trials, this is called the interventional management of stroke trial, where both the intravenous administration of TPA and mechanical removal of clot was shown to be beneficial. And there are two devices, the Mercy Retriever and the Penumbra thrombectomy device, that underwent trials that show there's a benefit to removing clot up to 8 hours. Now, you might say, why is this 8 hours and this is 4.5 hours? If you don't have to give clot-busting drugs, it limits some of the side effects of bleeding from that. So that's why it's a little bit safer to use these up to 8 hours. All right, so you're having a stroke, we've done the imaging. What are the parameters that we use to determine what should we do? We need to have an accurate time estimate of your stroke, what I call LSN, or last seen normal. If you go to bed normal and you wake up with a stroke, we call your last seen normal time when you went to bed. We don't know if you had a stroke 15 minutes before you woke up or 8 hours. And we certainly don't want to administer clot-busting drugs to you if it's been 8 hours. You have to have a bad enough stroke to warrant the treatment. We don't want the therapy to be worse than the disease. And some patients initially present with a significant stroke score, but then get better as we're watching them, as the clot may break up on its own as the body handles it. And those are patients that will say, we're going to stay away. Imaging study, very important. No bleeding and a stroke that's not big enough yet. The old data used to say you had to have a stroke that was less than 1/3 of the middle cerebral territory. Now we can add into that perfusion data. And as a matter of fact, that's going to direct future therapies, we think, rather than just time. So these are the things that will determine what kind of treatment you're going to have. What are the treatments available? Intravenous TPA, up to 4.5 hours. If you come in that time and you're having a significant stroke and you're not having bleeding, you're going to get intravenous TPA, because patients who get that do better than patients who don't. Endovascular therapy, that means when I go into your blood vessels and do something, I might consider intraarterial tissue plasminogen activator up to about 6 hours based on studies from the PROACT trial, or the other two FDA-approved therapies are the use of the Mercy retriever and the Penumbra device to remove the clot. And I'm going to show you what some of those look like. Let's look at a case and see what's going on. Here's a young woman, and 57 is getting younger year by year as I get older, who has been pretty healthy, but she had the acute onset of right-sided weakness. So which side of the brain is the problem? A for the day, all of you. Okay. And so she has right-sided weakness and aphasia, meaning she's not able to speak because that's your dominant hemisphere. So she ends up in our emergency room at 2.5 hours. Not great, but pretty good, we'll take it. On the non-contrast CAT scan, there's no bleeding, and I want you to look at this is our CT angiogram now. And I want you to look at the left middle cerebral territory right here, and you can see a blockage of the artery right there, okay? The power of the CTA. And here it is again on this so-called coronal view. That artery is blocked. And here is her perfusion study. You can see on the mean transit time, it takes a lot longer for blood to get to this entire territory, and that's a pretty big territory. And there's a lot of function there. I imagine she has a stroke scale score of in the 20s there, because not only is weakness and sensory function involved, but so is speech, and a lot of speech. And you can see that the blood volume, though, is a lot more preserved than the mean transit time. So if we do this red means stop and green means go overlay map, you see we have a lot of territory there. The ischemic penumbra is pretty large. There's a mismatch, we call that a mismatch of blood volume and transit time. So this is somebody that we might consider aggressively going after, trying to remove or bust up this clot, because this entire territory is at risk to have a stroke, but isn't dead tissue yet. So what are we going to do? This is a patient who would first get intravenous tissue plasminogen activator. But here, if the patient was early enough, we wouldn't stop there. Here's where we do our angiogram, and we place a tube in the femoral artery under sterile conditions, and here's my colleague, Dr. Hetz, performing an angiogram. This is like an operating suite with very fancy high-tech imaging equipment in there. And we're able to direct a small tube called a catheter all the way up the main blood vessel of the body called the aorta. Now this is the same way that cardiac catheterizations are done, but unlike cardiac catheterizations where we come around the top of the aorta into the heart, we take the exit routes that go north to the brain here, and here we've placed our catheter into the left carotid artery, done an injection of X-ray dye, and you can see the blockage of the left middle cerebral artery here. This is supposed to fill out in this fashion, and it's blocked completely there. So what we're going to do at this point is to try and unblock that clot. And our choices here, we've already given the intravenous tissue plasminogen activator. We can put up a smaller tube into the clot and infuse some of the clot busting drug, or we can use one of the clot removal devices. And in this case, we chose one of them here called the Mercy retriever, and you can see it looks like a corkscrew. And what we want to try and do is to get this corkscrew through the clot so we can get a toehold on it and gently tug it out of the body. So I'm going to show you a little movie and how this works. It's a vendor movie, and I apologize for that, but it at least shows you how this works. So there's the blood clot in the middle cerebral artery, and through the blood vessels, we take a small microcatheter and place it through the clot. Now what's interesting here is it looks good here, but the X-ray dye stops here, so we cannot see what lives on the other side. We're doing this blindly. And after our catheters in there, we deploy this little corkscrew device to try and grab the clot. A larger tube that we have down lower in the carotid artery allows us to inflate a balloon to stop the blood flow, because we don't want to catch the clot and then have it break off with the flow, and then we pull it out of the body that way. Now I will tell you that It's a lot harder to do than this cartoon suggests, but that's why, I guess that's why the Concentric company makes some money. So this is what that actually looks like up in the brain. This is reversed, I apologize for that. But you can see on our image of an angiogram, there's the corkscrew device pulled onto that clot, and we're trying to tug it hard enough to get it out, but not so hard that we're going to lose the fish on the line, so to speak. And it's a little scary because this does distort some of the blood vessels as you're pulling through it. And hopefully we'll get that thing snagged and get it out just as you see there. That's the bonus here. This is the fish on the line. This is the corkscrew device in the brain, and this is what we got out. You can see this is the corkscrew device here. It's got even some fishing line in here that helps us ensnare the clot. That's a pretty big clot. This is 1 centimeter from here to here, and there's 2 big chunks of clot that we get out of there. Can I tell you, there's nothing more satisfying than this. Not only is it fun, you're actually helping somebody. And I can tell you in my almost 24 years of doing this, the best cases of interventional neuroradiology that I've done are the acute strokes, especially in the younger people. It doesn't always work, but it's very gratifying when you can do it. Now, we want to go from here to here. And you can see we've restored blood supply to this part of the brain. The picture only tells part of the story, because if we do this too late, we're not going to save those blood cells supplied by those blood vessels downstream. That's where the judgment comes in. That's where the perfusion studies come in. That's where the time element comes in. But it is gratifying to take a patient with this large of a volume of ischemic penumbra and to save them to have just a little tiny stroke in this part of the brain, and they've recovered very nicely from that. So that's the power of what we're able to do now that we can do this. One more thing I want to show you. There's another device I talked about. This is another way to remove blood clot, and let's show you how that's done. This is a small catheter that's placed in there, and the clot is actually sucked right out of it. So there's our blood clot, and we direct a tube there through which we apply some suction on the other end. And we turn on the suction, we aspirate gently that blood clot, and we have a little baffle at the end that we use to manipulate that clot and to clear the line and to get that out. This is called the penumbra thrombectomy device, and this is the second of the 2 interventional devices that have been approved. It's a very exciting time for me because companies are really working hard to approve these stroke therapy devices, so it's a very good time to be in my field. And hopefully, as it's taking a while for this cartoon to move through, we go up and we get all of the clot right out of there. And here's a case in point. Here's a patient who has a blockage of his basilar artery, and this is really a terrible stroke because the most primitive part of the brain is deprived of its blood supply. And you can actually see the outline of the clot that sits right there by the x-ray dye. This is a view from the front, this is a view from the side, and what we decided to do is take a small tube, put it up into the clot. Because we thought the clot was so extensive, we did drizzle a little bit of tissue plasminogen activator into the clot to basically lace it with the seeds of its own destruction. And then we went up with the thrombectomy device, and we went from basically a blocked artery to an artery that's not completely perfect, but pretty good. And as you can see, the patient left the hospital 2 days later with no neurological deficit. Now, we have a saying here. That wasn't a perfect angiographic result, but we took a person who was going to die and allowed them to survive and walk out of the hospital. And that saying we have is, better is the enemy of good. Here's a case where we've unblocked a basilar artery clot, and this artery is still a little blocked, and this patient has had a little stroke. But if you try too hard, if you push too late, if you give too much clot-busting drug, you can go from that to that. And that is essentially a hemorrhage that this patient won't survive. That's why the judgment is so important in what we do. It's not just pull out the guns and go down with both guns blasting all the time, because these are delicate therapies and you can make a patient worse. So what is our protocol? And by the way, this is our UCSF protocol is devised by the head of stroke neurology, Wade Smith. You don't have to remember all this. It won't be on the test. If you get here within the first 4.5 hours and you have a CT scan that shows no hemorrhage and all the blood vessels are open and we think you have a significant stroke, you're still going to get intravenous TPA. So you'll get that even if you have a small vessel stroke. If you have a large vessel stroke, if you have a blockage of a large vessel, you're still going to get IV TPA in the first 4.5 hours, and we'll consider some endovascular intervention if we think it's appropriate, and we can get there based on the imaging studies. If you get there at 4.5 to 8 hours, you're no longer eligible for the IV TPA, but we'll consider endovascular. Now, these devices that I've talked about are only approved to 8 hours, so once you get beyond that, we're talking about the future realm of image-guided intervention. Is your ischemic penumbra enough to cause us to want to go in there, even though the clock says we're very late on your stroke? And that's why we're going to be moving from, I think, a time-based approach to an imaging and perfusion-based approach. Now, there are a lot of things that determine how you're going to end up with your stroke. And I'm not going to go through all of those, but I'm going to boil this down to, are we making a difference with all the stuff that we do, with the public education that we're doing, with the new devices and the approval of the drugs? In the decade of the brain, which was the 90s, into 2005, the stroke death rates fell almost 30%. That's a pretty good number. So we're saving more people. We don't want to save them to be devastated. We want to save them to have healthy lives. The trial that demonstrated the benefit of tissue plasminogen activator given intravenously, these patients did better at 3 months and were 30% more likely to have no disability or just a minor disability than a group that didn't get it. So this says if you're eligible, you should get IV TPA. The multi-Mercy trial for the Mercy Retriever device achieved 60+% recanalization, which is related to better clinical outcome. We do believe that opening a blood vessel in a timely fashion will benefit the patient, but what's most important is how the patient does, not how the pictures look. And likewise, the Penumbra pivotal trial for the Penumbra catheter was able to achieve flow restoration about 80% of the time. And these are small trials, but these are the trials on which the approval of these devices are based. And I can tell you, this is about the most gratifying thing you can see. This is an article from the San Francisco Chronicle. It's a lot better than the article from the New York Times nearly 100 years ago of somebody actually succumbing to a stroke. This is a young woman who survived the stroke, and she was going to die, ended up here, and we provided many of the interventions that you see here. And with our good group of people, we were able to save her. And that's about as gratifying as it gets, not only in medicine, but in life. Remember, we talked about moving from a time-based stroke therapy decision tree to a physiology-based stroke decision tree. That will be the future for us, and you're going to see more and more of that. As I end, I want to thank my colleagues in my section, Interventional Neuroradiology, in the San Francisco General and Veterans Hospital Interventional Neuroradiology Service. I have to acknowledge them. I trained those guys, and they do a really good job. And our neurovascular or stroke neurology service, we have the best team in the world here. And I have the pleasure of working with all of these people on a daily basis. It takes a team to be able to do all this. So, what did we learn tonight? We talked about stroke definition, classification, and a little bit of anatomy. We talked about epidemiology and risk factors. We talked about the warning signs of stroke. Remember, FAST. We talk about what happens after you have a stroke and how you get to therapy. We talked about how important imaging is, and we talked about the 3 elements of the CAT scan that is used here: non-contrast imaging, angiography, and perfusion studies. And we talked about acute stroke therapy. The 3 FDA-approved therapies now are intravenous tissue plasminogen activator, the Penumbra catheter, and the Mercy retrieval catheter. And I want to thank you for your attention. There will be no final exam. I was just joking. It's a great pleasure to be with you tonight, and I hope you've enjoyed it as much as I had. Thank you very much. Questions? I'm sorry, no questions. That's the end. Sir.
How often is atrial fibrillation related to one of the other risk factors that were up there, like diabetes and things like that. And I'm wondering, if you have a heartbeat irregularity, without any of those risk factors, does it usually produce atrial fibrillation?
Well, you can certainly have atrial fibrillation without those other factors. Oftentimes, it does go along with some of those other factors, but it can also exist in isolation. Now, I'm not quite sure about the second part of your question. If you have an irregular heartbeat, does it produce atrial fibrillation? Was that your question? Well, it may not produce it. It may actually represent it. So if you have an irregular heartbeat, and I'll take your pulse on the way out for a fee, just a joke, you should have that checked out by a physician, because you can certainly have occult atrial fibrillation without and not know it and not have any symptoms. Some people get it transiently and it feels a little bit like a fish jumping in their chest, and then it goes away. But if you have it on a more than occasional basis, you should have that checked out. Because your heart could be pumping enough to get plenty of blood supply to the rest of your body, and you could still be at risk for producing these clots in the left atrium that can break off and go to the rest of the brain. So it's not that an irregular heartbeat produces atrial fibrillation, it may actually represent atrial fibrillation. Yeah, his question was, if you see any of the symptoms that I described in my FAST acronym, face, arm, speech, time, what do you do if they seem to be getting better, or can they come and go, or are they intermittent? If you think they're there, I wouldn't wait. Let's say that you have a transient deficit. We might categorize that as a TIA instead of a stroke. And we see 40% of people who have TIAs will end up having a stroke. So even if you think the patient is cleared up, I would take that seriously, because this is a patient who may have occult atrial fibrillation, or may be hypertensive, or may need some risk factor modification, and the sooner you do that, the better off we're going to be.
And taking it seriously means, I assume, 911 as opposed to driving.
Yeah, well, okay, let's say you get in the car and drive. You could drive right off the road and maybe take a couple of folks with you. So that's not a good idea. I know, listen, nobody wants to call the ambulance.
I was driving her.
Well, think about her driving you. Next.
For the retriever and the penumbra device, is the patient generally anesthetized?
That's a good question. There's a debate among us about this. We're really good here. We like to provide super service. We like to provide penthouse service. We have, as soon as I hear about a stroke, I'll call our anesthesiology team. And I say, I got a stroke, I need your help. And they know I don't call them, I don't cry wolf to them. They know when I call, I need them. So they provide me an anesthesiologist on call 24 hours a day. Now that doesn't happen everywhere, at every hospital. I think it's safer to take a patient and quickly anesthetize them and keep them still while you're trying to maneuver on a 2-millimeter blood vessel in the brain than to have them confused and writhing around in there. It's my personal preference. Some people think that there's a cost in time to having an anesthesia team. I think it's a small amount of time very well spent for the expertise that it provides. So at this institution, you will be rapidly induced into general anesthetic while we're doing all this. A lot of things are happening at once, including being intubated and placed under general anesthesia as we're getting the tubes in and so forth. I think that's a small price to pay here, but there's a debate now about that. Sir?
Often the speech center on the left side of the brain, is that related to hearing?
Yes, it is. Good question. Ready for second year medical school. Most people have speech on the left side of the brain. Most of us, 90% of us, are right-handed, and the vast majority of right-handers have speech and memory on the left side of the brain. Now, as it turns out, there are two kinds of left-handers. Congenital left-handers, meaning there's a lot of left-handedness in the family, and there's a new theory out, I guess it's not such a new theory, that some left-handers who don't have the congenital component to it, or the genetic component to it, I should say, are left-handers because of some brain damage. Now, that's kind of a bad sign to put on Ted Williams, who batted left-handed. Maybe he bats left-handed and hit 400 because he was brain damaged. But A higher proportion of lefties will have speech in the right side of the brain, but still the majority will have speech in the left side of the brain. So you just can't tell from looking at somebody knowing their handedness or even looking at the brain itself. We just assume that the left hemisphere is dominant until we figure out otherwise. Next, sir.
Other than UC, what other hospitals are?
Oh, you're going to ask me to advertise the opponents now. Stanford's got a good stroke program. CPMC is starting one. San Francisco General is terrific, top notch. The VA generally doesn't get acute strokes there because it's not an acute stroke program. I don't know what the Kaisers are doing. I'm sure they have something. There's a real move afoot in medicine to get stroke certified. And unlike 10 years ago when nobody was, everybody's scrambling to do it. But you have to really clear a lot of hurdles to be able to do it. Ma'am.
Now, is taking a low-dose aspirin daily, is that still a good idea? I guess there's a change in thinking if that's really going to reduce the risk of stroke or not.
Well, this sounds like the person who's selling you the stocks. You should really check with your tax advisor on that. You really should check with your doctor because there are pros and cons of antiplatelet therapy. I take a baby aspirin a day because I'm a male, I'm over 50, and the statistics are with me to do that. Now, the risk of taking aspirin are the bleeding effects. It might mean that if I had high blood pressure, I'd be more likely to have bleeding into the brain, although it might prevent me from having blockage or a heart attack. There's also, it can irritate the stomach or the intestinal lining, and you can have gastrointestinal bleeding. So there are pros and cons. There is a definite benefit to antiplatelet therapy if you're the right person. But I wouldn't say that everybody should take a baby aspirin a day. You're a young woman, you may be below the time that you need to take that, but I would check with your doctor. And remember, after a certain age, you're back with the guys in terms of your risk factors for the development of atherosclerotic disease.
Back to the hospital by hospital comparison, it sounds like a place like San Francisco is well equipped. But let's say I'm out in, and I don't want to disparage any cities, but let's say I'm in Cloverdale, and there's a hospital there, and they've just become stroke certified. Is there stroke certified A versus stroke certified B?
Yeah, there are levels of that. But let me put it another way. We might get a call from Reading, you know, Pops is having an acute stroke. We're not going to get you down from Reading in time to be able to do anything for you. So if you're in Cloverdale or Reading or Timbuktu, you're where you're going to be treated. And so you can't do anything about it. Yes, I do believe that there are certain different levels of stroke certification. I believe we have the highest level here, which includes the interventional property, which is probably the most difficult component to have. But yes, there are different levels. But if you're in a certain place and you have a stroke, you really don't have a choice of where you're going. You might in San Francisco, but you don't in Timbuktu.
And by interventional, you mean mechanical?
Yes.
Because they will have the TPA.
Well, we hope not all hospitals even do that. No, not all hospitals do that. You might end up in an emergency room that doesn't have a neurologist or a neurosurgeon. Neurosurgeons wouldn't do it, but a neurologist would be ready to do that. That's unusual in the Bay Area, but certainly in the middle of nowhere that could happen.
Regarding TPA, what if they look at you and it looks like you've had minor strokes before that were never treated? Will you administer TPA or have the risk of bleeding? That's
a very good question. So in other words, when is the last seen normal time is what you're really saying. Where do we start the stopwatch for the stroke? If you have a series of stuttering strokes that come and go, we'll generally categorize those as best we can, perhaps as TIAs, and then we'll call the time of onset of your stroke the last time you started this whole shenanigans again. But that's getting a history is a very important element of what we do because it's crucial to make these determinations.
Did you call 911? They come, you've got a stroke. Where did they take you? Did they take you where you asked to be taken, or did they take you to the nearest stroke?
Well, I've never been in that situation. I imagine they could take you where you want to be taken, but if they think you're having a stroke, they want to take you to a stroke place. Right. And it's not as if we pay these guys to go certain places. They want to take you to the closest, highest rated place that there is. I don't worry about insurance And you're not going to worry about me because if I'm your doctor, you're probably comatose right now. So that's not insurance and administration. I can't stomach all that. I let somebody else worry about that. I just want to take care of you. Sir.
To follow up on the time issue, how long does it take to run someone through the test where you have the scale of 0 to 42?
The NIH Stroke Scale score? Yeah, you can kind of blow through that in about 4 or 5 minutes.
Is it necessary to go through the whole thing? I mean, your next step is to go to the CT scan, right?
Yeah. Oh, I see where this is going. You're a pro radiology here. The heck with the evaluation. This is called the theory of one scan is worth 1,000 neurologists, which is what radiologists tell our neurology colleagues all the time. Yeah, it's important because if you have, we'll examine you, determine the severity and degree of your stroke, and we like to quantify this so that we're all talking the same language by the use of the stroke scale score. The imaging isn't a substitute for that. It's icing on the cake for that. And if we know that you're a 22 and then we examine you later and you're a 14, you're improving considerably. We might decide not to do something. So it's important that we do that as well. I don't think that the administration of the NIH Stroke Scale score is really a time waster here. I think it's an important part of it, but it's not substituted for by imaging alone, if that was your question. If I can translate, your question is, you have an aneurysm that's not ruptured and you haven't had bleeding, and in that scenario you also have a blockage that causes you to have an ischemic stroke. Is that what you're talking about?
Both, but also what if you just had an aneurysm, which from what I heard, you get a really, really bad headache, but how, do you catch an aneurysm and then you can repair it?
Yes. We're very much known for treating aneurysms, in particular ruptured aneurysms, at this institution, which you can do either surgically or endovascularly. And I've spent a large part of my career doing exactly that. Yeah, there's a lot of that. If you have an aneurysm, we'd like to determine whether or not we should treat that before you have the bleeding episode that we talked about. Okay, the most likely thing you would have if you had a ruptured aneurysm is what we call the worst headache of your life. That's a very painful event. In addition, you may get the acute onset of a focal neurological deficit related, in this case, to a vascular event, but it's a hemorrhagic vascular event because the pipe is leaking, not because the pipe is blocked. But yeah, usually that comes along with whatever else you get, and you could. One of the unfortunate presentations of a ruptured aneurysm is instant death, which happens to about 15 or 20% of patients. But for those who survive, worst headache of life is probably the most common complaint. And thank you very much. You've been a great audience, and you've all completed mini medical school, and now you're all mini doctors. Thank you for coming.